Hello and welcome back to Part 2 of 12-lead ECG interpretation. As mentioned before in Part 1, I developed this dialogue as a supplement for my paramedic students to follow up on the in-class lecture component to their initial education course. Please review the textbooks for the course listed on this slide in which this lecture was based for any further information. In today's lecture, we are covering the following objectives. Understand what bundle branch blocks are, how to differentiate between a right and left bundle branch block using V1 of our 12-lead printout, describe the clinical significance of a bundle branch block, and the diagnostic problems associated with a left bundle branch block. Let's start with a quick overview of the electrical conduction system of the heart. The SA node is the primary pacemaker, and the electricity is conducted through the internodal pathways to the AV node at the bottom of the right atrium. From here, electricity travels to the bundle of His, and the bundle of His connects to the bundle branches, which travel down through the septal wall that separates both the right and left ventricle. When electricity travels down the right side of the septum and swings around to feed the right ventricle, it does so through a single fascicle, in which you will see is very different from the left side. On the left ventricle, electricity travels down the left side of the septal wall and splits into two fascicles, an anterior fascicle and a posterior fascicle. And just a reminder that left ventricle is considered the powerhouse, and because it has to overcome greater pressures to contract and push blood out of the heart, it needs to have two fascicles in order to do the job. Under normal circumstances, the left and right ventricle will depolarize simultaneously. But if a blockage occurs in a bundle branch, then the ventricles will depolarize at separate intervals. Now that we have reviewed the structural presentation of the bundle branches and the fascicles, let's find that bundle branch block on your 12-lead printout. In order to meet the criteria to be called a bundle branch block, the QRS interval must be greater than 0.12 seconds or 120 milliseconds. This is something you can quickly determine at the top of your printout, as seen in this example where the QRS is 144 milliseconds or 0.14 seconds in duration. Once you have determined that the QRS is greater than 0.12 seconds, you go to V1 on your printout. V1 is the only lead we will use to call a bundle branch block in this class. When you look at V1, you will want to find the J point and draw a line back toward the complex and shade either up or down as it allows. The J point is after the QRS, when the complex returns to the isoelectric line or transitions into the T wave. Both textbooks advocate the use of the turn signal method as a means to name the bundle branch block as either right or left in nature. Take, for example, if you're driving a car and you want to turn right, what direction will you flip your signal light? You will flip it up. Anytime you shade back from the J point into the QRS and you shade up, that indicates a right bundle branch block. And the opposite is true. If you wish to turn left in your car, you're going to flip your signal light down. So if you move back from the J point and shade down, this indicates a left bundle branch block. Let's review that one more time. On the top row in step 1, we find the J point has been circled for us. Now in step 2 and 3, we begin shading back into the QRS, clearly showing a downward shading, which indicates a left bundle branch block. On the bottom row, we find the J point circled in step 1, and we begin to shade back into the QRS. This shows an upward deflection, indicating a right bundle branch block. So what's the big deal anyway? While a bundle branch block can be temporary, it is of major concern in those patients who are suffering from a myocardial infarction, because a bundle branch block indicates extensive coronary artery occlusion and myocardial wall damage. If the printout indicates a left bundle branch block, it is important to know that this will obscure the ST segment and make it difficult to diagnose an acute myocardial infarction in the field. It is always a good idea to ask the patient if he has a copy of a previous 12 lead that may have been taken on hand and transport it with you to the hospital. That way the receiving facility can compare and identify any new changes from the old 12 lead to the one that you printed during the call. At this point, we need to think back to our discussion in part 1 using the axis and hemiblock chart. If you reviewed the printout for axis deviation and found either a pathological left or a right axis deviation, then you know a hemiblock exists. This means that one fascicle is blocked. Now look at V1 of that same printout. If you find a right bundle branch block, then you have a total of 2 fascicles blocked. This is referred to as a bifascicular block. Because the left ventricle has 2 fascicles, should you see a left bundle branch block in V1, you automatically have a bifascicular block. What's critical to understand is that the normal medications we use to treat some wide complex arrhythmias and some of our chest pain patients can cause further deterioration and potentially death. So it pays to be very vigilant and stay educated on proper diagnostics and treatment methods. And remember, always, when in doubt, confer with your medical command center and the physician for proper treatment choices. Because the bundle branch blocks cause the ventricles to fire out of sync, you can expect to see hemodynamic changes in your patient, such as a decrease in preload or delays in conduction and depolarization time. A normal ejection fraction should be between 60 to 75%. In cases where the QRS complex is greater than 0.17 seconds, you can very much expect to see an ejection fraction of less than 50%. Now, the brain is smart enough to recognize this change in the ejection fraction and is going to try to compensate for that loss of preload by causing the blood vessels to constrict in order to improve it. Unfortunately, the vasodilatory meds we like to give, such as nitroglycerin, will hinder the body's attempt to compensate through vasoconstriction, and this can cause a serious drop in blood pressure. I have a few printouts on the following slides that I included just to make sure you know how to find the Let's try this again. How to find the bundle branch block. Okay, so at the top of this printout, find the QRS interval. Is it too wide? It is. It is actually 144 milliseconds or 0.14 seconds. So now where do we go? Go to V1. Find the J point. At the J point, shade in toward the QRS complex. What direction are you shading? You are shading in a downward deflection. So what bundle branch block is present? If you said a left bundle branch block, then you are correct. Now, what's the QRS interval on this one? Is it wide? It is. The QRS interval is 186 milliseconds or 0.19 seconds. So now what? You're going to go to the V1 and find the J point. What direction are you shading in? If you said upright, you're correct. So what bundle branch block is present? If you said a right bundle branch block, then you're correct. Here's your final one. What is the QRS interval? Is it long enough to meet the criteria to be a bundle branch block? If you answered no, you're correct. The QRS is only 118 milliseconds or 0.12 seconds, which is considered within normal limits. So there's no need to look any further. All right, since your confidence is up, let's incorporate axis and hemi blocks from Lesson 1 into our interpretation of bundle branch blocks. So get out your Bob Page axis and hemi block chart and let's get started. Here's the first printout. Start at the beginning with the axis deviation. Compare leads 1, 2, and 3 here to your Bob Page chart. Lead 1 is upright. Lead 2 is primarily down. And lead 3 is also down. What do you want to call this? If you set a pathological left axis, you are correct. Now, the next step is to look at the QRS interval. Is it wide? It is. It's 140 milliseconds or 0.14. So where do you go now? All right, so we're going to go to V1. Find the J point and shade it in. What direction are you going? You're moving in a downward deflection. So what bundle branch block is present? If you said a left bundle branch block, you're correct. Now, is this considered a bifascicular block? Yes. Anytime you have a left bundle branch block, then two fascicles are blocked. So you always want to talk to medical command and determine the proper course of treatment. Remember, nitroglycerin can cause a huge drop in blood pressure. Okay, so here's your next patient. Let's see how you do. Find out what the axis deviation is first. So we're going to go look at lead 1, and it is primarily down. Lead 2 is upright, and lead 3 is upright. What's your axis deviation? If you said that you have a right axis deviation, you're correct. Does this indicate a hemiblock? Yes, it is a posterior hemiblock. Or you could say that the posterior fascicle on the left ventricle is currently blocked. So now let's look at the QRS interval. Is it too wide? Yes. It is 126 milliseconds or 0.13 seconds. Where do you go now? Go to V1. What direction are you going to shade? And what bundle branch block is present? If you said that this is a right bundle branch block, you are correct. Based on the fact that you have a right bundle branch block and a posterior hemiblock of the left ventricle, is this considered a bifascicular block? If you said yes, you're correct. And if you paid attention to the top, you'll see it gives you this information. But don't forget the 12 lead isn't always accurate in the cases of heart blocks and wide complex tachycardias. So this wraps up part 2 of the 12 lead lecture series. Please feel free to visit me at authorstream.com on my channel, Paramedic EDU. Thank you for your time, and I look forward to seeing you in class.